Hello and welcome to this video on the concept of dentally referred pain. I am Tanya Chamberlain from the Division of Anatomy at the University of Leeds, and in this video we will be looking at some of the red herrings you may see in practice. Before we explore today's learning objectives, let's have a recap at the pathways associated with the trigeminal nerve and therefore the sensory information to the face. On this side, we are looking at a coronal section of the brain. Firstly, let's remove the cerebellum to help tidy this image up. It would be really helpful if we could throw in some of the nuclei that are going to be relevant today. Let's recap the structure of the brain. First, we have the cerebrum. The cerebrum is surrounded by the cortex, which is where we find the sensory pathway termination or the motor pathway start. We also have the diencephalon. This is where we locate the thalamus, which, remember, acts as a switchboard or relay station for directing messages to the appropriate area of cortex. We have the midbrain, the pons, and the medulla, which collectively form the brainstem. We should also take the time to recap the nuclei, which we will be looking at more closely. First up is the thalamus. Strictly speaking, the thalami aren't nuclei, but instead are a collection of 60 nuclei. However, for the purposes of this video, we will consider the thalamus as a whole single place of synapse, as when we consider the different nuclei within the thalamus, it gets extremely complicated, and it's hugely unnecessary for what you need to understand. Here we can see the first of the 4 trigeminal nuclei. This is the mesencephalic nucleus. The chief nucleus, which you may see referred to as the principal or the main nucleus. The motor nucleus, which is responsible for sending motor fibres to the muscles of mastication. And finally, the spinal nucleus of the trigeminal nerve, which we focused on a few videos ago. This sketch is a very simplified perspective of the sensory nuclei, as in reality they merge together down the whole of the lateral sides of the brainstem. But this would have made what we are going to talk about today very hard to follow. For the purposes of today, we will imagine that they are distinct regions. We should review the trigeminal sensory pathways. We could see that the 3 branches of the sensory division of the trigeminal nerve converge at the trigeminal ganglion, where they house their sensory cell bodies. The root of the trigeminal nerve enters the pons and is able to project their first order neuron onto the appropriate trigeminal sensory nuclei. In the event that the proprioceptors receive stimulus, these first order neurons project onto the mesencephalic nucleus. In the event that the touch receptors are stimulated, these first order neurons are projected onto the chief nucleus. In the event that the nociceptors or pain and temperature neurons are stimulated, the first order neurons are projected onto the spinal nucleus. All of these first order neurons are projected onto the ipsilateral nuclei. Once these first order neurons are at their appropriate nuclei, they synapse onto a second order neuron which enters the contralateral trigeminal thalamic tract. In other words, it crosses the midline and arrives at the contralateral thalamus. This image does not show that clearly, but you'll understand why I've left it on the same side as we move through, as the picture gets rather complicated if we swap it over. But please remember that as soon as that second order neuron is synapsed, it crosses the midline straight away and enters the contralateral trigeminothalamic tract. From the thalamus, the second order neuron is projected onto the somatosensory cortex, the post-central gyrus. Now we've caught up, let's focus on the learning objectives on this video. By the end of this video, you should be able to outline the neuroanatomical mechanism in which pain affects the sleep-wake cycles and hyperarousal that manifests in patient symptoms. You should be able to describe the mechanism by which the central nervous system tries to mitigate pain. You should also be able to outline the pathways of referred pain within the head and neck. Explain how sinus infections, ear infections, and cardiac disorders can present as craniofacial pain. and explain how the symptoms of trigeminal neuralgia arise in line with current research. The first thing we should look at is the effects of pain on the sleep-wake cycle. Patients with pain, particularly chronic pain, often mention that the pain feels worse at night, and as a result of this, the pain prevents them from sleeping. On this image, we can see these nuclei have been labelled. These are the reticular formation, and they play an important role in the sleep-wake cycle. As we can see, the first order neurons are travelling from the trigeminal ganglion and synapsing on the second order neuron at the spinal nucleus of the trigeminal. Now, I know this image isn't strictly true because we know that second order neuron crosses immediately, but remember I said that we're going to try and keep this as simple and as clean as possible. So we have to imagine that it's ascending on the contralateral trigeminothalamic tract. If you need to recap the pathways of the trigeminal nerve, please rewatch the toothache video. On here we can see the first order neuron is synapsing at the spinal nucleus of the trigeminal nerve. What also happens here is a second order neuron synapses at the reticular formation. As we have said, the reticular formation has an important role in the sleep-wake cycle. Sending pain transmissions to this area can reduce the sleep or quality of sleep, which promotes sleep deprivation or disturbed sleep in patients experiencing pain. There is another pathway that the neurons often take too, and this one is going to apply to the emotional aspect of pain. This involves a region of the limbic system part of the brain, or more specifically, the amygdala. Second order neurons can synapse at the amygdala. The amygdala and the limbic system are very ancient parts of the brain. What we mean by that is that they are shared by many of our close and distant animal relatives. They work to make us fearful and prevent us from getting into situations that may harm us. If we have a past experience of pain from an event, this memory is stored in the limbic system and reminds us that undertaking this particular action caused us pain. This suggests that we should probably avoid repeat performance of this scenario. If we think about this from a dental perspective, a cavity in a patient's tooth may make them avoid chewing on one side of their mouth because it hurts. The patient then seeks treatment and the cavity issue is resolved immediately. It can be a few days or even weeks before the patient resorts to chewing food on the affected side because they are still battling with their limbic system, as the memory of pain is preventing the action of chewing on the affected side. This also explains why some patients develop dental phobias. One bad or painful experience at the dentist can dissuade the patients from seeking dental treatment in the future. So this is something to bear in mind when treating your patients. Something else to think about is the physical effects of pain on the patient. Some patients report their heart beating faster, some report sweating. In people and animals, we see that pain causes an increase in pulse, blood pressure, and respiratory rates. In some patients, we even see that it results in increased perspiration. This is because pain can trigger a systemic effect on the sympathetic nervous system. Second order neurons also synapse at the hypothalamus. The hypothalamus is the part of the brain responsible for the endocrine system. It monitors and changes hormones within the body. When stimulated by second order neurons in the pain pathways, the hypothalamus secretes hormones which instruct the adrenal glands to secrete adrenaline. The secretion of adrenaline promotes the heartbeat to fire faster, a faster respiratory rate, and prepares us for fight or flight. Pain is useful to us because it keeps us safe, but the body itself doesn't particularly like pain because it can prevent us from undertaking safe and necessary tasks. Pain is only beneficial short term when there is an increased risk of damage. But when that damage is resolved, or when we need to be able to function whilst in pain, how does the brain dampen down the pain transmission so we can go about our daily business? Well, this is one of the pathways in which it can be undertaken. Here we can see fibres in the second order neuron pathway are able to synapse with a really cool region of the brain called the periaqueductal grey matter. The periaqueductal grey matter can also synapse with the raphe nuclei in the midbrain, just below the fourth ventricle. Let's zoom in here so it becomes a little clearer. Neurons in the raphe nuclei synapse onto an interneuron. Which release serotonin as a neurotransmitter, which acts to inhibit the second order neurons from transmitting pain to the thalamus. In effect, what we have done is turned off the transmission of pain. Serotonin is strongly associated with mood too, which is why we see a lot of pharmaceuticals that are prescribed for mood disorders like depression and anxiety. We've found them to be useful in the treatment of chronic pain disorders as well. That was quite a lot of information to take in, so let's have a look at where we are on our learning objectives list for today. So this learning objective has been addressed so far by looking at the previous section, but now we need to address a theory about how pain is generated. One of the leading theories, and thankfully the only one we are going to address today, is called the convergence projection theory. And in summary, this is what the theory encompasses. The idea that many first-order neurons synapse onto a single second-order neuron. Let's take a look at an example. The image on the left is a very simplified trigeminal nerve, and on the right we have a blown-up version of the trigeminal ganglion and the medulla, showing two portions of the spinal nuclei of the trigeminal nerve. Again, this is very simplified because I want you to be able to see an overview of the whole process here. This nerve is the inferior alveolar nerve. In this case, we are seeing branches of the inferior dental nerves coming from the mandibular dental incisors. The inferior alveolar nerve travels within the mandible towards the trigeminal ganglion, where its sensory cell body sits, and it passes through to the spinal nucleus where it synapses onto a second-order neuron. On the left, we can also see the nerve to the mylohyoid, which innervates the anterior belly of the digastric muscle. So it has muscular but also sensory components. We are only interested in the sensory functions today. The sensory fibres travel up to join the mandibular branch of the trigeminal nerve through the ganglion where its sensory cell body is housed, and these also synapse at a second-order neuron in the spinal nucleus. Here we can see that the two first-order neurons are synapsing on the same second-order neuron, which is how we perceive pain from one area when the noxious substance is actually stimulating the first-order neuron from a different area. In this particular example, damage in the submental region of the face can be referred to the mandibular incisors, which would explain why the patient visited their dentist over the general practitioner. Here I have stuck in an extra slide which wasn't in the lecture, but it was inspired by talking to a student. Imagine that two trains on separate train tracks converge onto a single line that ends up at the cortex station. One has come from the mandibular central incisor station. One has come from the submental station. If you are waiting at the cortex station and the train arrives, you have no way of knowing whether the train came from the mandibular central incisor station or the submental station, because both have shared a common pathway, that same second-order neuron from the spinal nucleus. As pain is interpreted in the cortex, there is a slight confusion of where that pain originally came from, or where the noxious substance originated. So in the body, referred pain largely exists within the same dermatome, and in the face, referred pain will largely be interpreted in the same branch of the trigeminal nerve. However, this isn't always the case, and there are some limitations to this theory because not all referred pain follows the dermatome rule. Let's go and have a look at some red herrings that might encourage the patient to visit the dentist. Here, we have 4 cases that all seem like dental issues at face value. Pause the video and read each case, and then we will go through what might be happening. So in order to know why we have these red herrings, we need to know a little bit more about the spinal nucleus. Remember, this is a very simplified diagram, and remember that the second order neurons cross immediately to travel within the contralateral trigeminothalamic tract. But for the sake of cleanliness, I've contained everything to one side. The spinal nucleus also receives first order neurons from other sensory cranial nerves too. It receives first order neurons from the facial nerve, the glossopharyngeal nerve, and the cardiac branch of the vagus nerve, and some of these will synapse onto the same second order neuron that the mandibular branch of the trigeminal also synapses onto. So we can get referred pain from the glossopharyngeal, vagus, and facial being perceived in some regions in which the mandibular branch of the trigeminal nerve innervates. Let's go back to our cases and see this in practice. The first case is this 30-year-old patient who presents to the dentist with pain in the bilateral molars. Her examination was fairly normal except for mild teeth grinding is evident. She says that the pain sometimes moves into her temporal region. Over-the-counter medications and non-steroidal anti-inflammatory drugs help to mitigate the pain. So what is going on here? The patient is grinding her teeth. Think about the muscles that allow for teeth grinding. We're all thinking about the masseter. The masseter is innervated by the mandibular branch of the trigeminal. Think about the action of grinding your teeth. Not only are you increasing the wear and tear of the teeth, but also to the TMJ. What branch of the trigeminal nerve innervates the capsule of the TMJ? The auriculotemporal from the mandibular branch. She also complains of pain in her temporal region. What branch innervates the temporalis muscle? Once again, the mandibular nerve. Remember that the temporalis muscle is a muscle of mastication, so is innervated by the mandibular branch. Pain being perceived in the teeth. What innervates the mandibular molars? The inferior dental branches from the inferior alveolar nerve, which is from the mandibular branch of the trigeminal. All of these branches will synapse at the spinal nucleus of the trigeminal nerve, but may be synapsing on the same second order neuron, and therefore the cortex is unable to determine where the noxious substance or train originally came from. Case 2. This was our 25-year-old patient with left maxillary premolar pain. They are normally well but have recently had a terrible cold. On examination, the teeth and mucosa were unremarkable, meaning that there was nothing obviously wrong with the teeth or mucosa. First thing we should shout out is that the patient has recently had a cold or upper respiratory tract infection. From our anatomy, we know that the relationship between the teeth and the upper respiratory tract are very close. With a cold, patients often can experience inflamed sinuses. The maxillary sinuses are fairly prone to inflammation and infection. The mucosa of the sinuses are innervated by the middle superior alveolar nerve, which we know also innervates the maxillary premolars. This means that pain from the maxillary sinuses can be perceived as coming from the teeth on the same side. So you would expect referred pain from the left maxillary sinus would be seen in the left maxillary premolars. You would not expect that this would be contralaterally presented. Case 3 was a young patient with right-sided jaw pain. He's normally well but known to have repeated middle ear infections. He's recently had an ear infection which was treated with medication and seems to have resolved. Let's look at some of his history. First up, the patient has ear infections, also known as otitis media. Near the middle ear is a passage of the chorda tympani, part of the facial nerve. On this image, we are looking at the middle ear, and we can see the close relationship of the branch of the facial nerve, the chorda tympani. We know that we have branches of the facial nerve synapsing in the spinal nucleus of the trigeminal nerve. Therefore, we know that the cortex is unable to determine the origin of the noxious substance, and the pain from the ear is being perceived in the TMJ, which is innervated by the auriculotemporal nerve of the mandibular branch. Now, our final case is very interesting, but you'll see it makes perfect sense when you interpret the anatomy. This 64-year-old male presents with dull jaw pain, but has no signs of TMJ dysfunction. What we do know about this patient is that he has CHD and hypertension. So let's first think and consider his past medical history of coronary heart disease. Also the presence of high blood pressure. This puts the patient at risk for ischemia of the heart muscle or even an infarction of the heart muscle. These are commonly known as angina or myocardial infarction. The myocardium or heart muscle is innervated by the cardiac branch of the vagus nerve, which we know will synapse onto the same second-order neurons that the mandibular branch of the trigeminal will also synapse on. Therefore, it might be that this patient is having cardiac events, but the cortex is unable to determine where the pain originates, whether it's from the heart or the jaw. So those are interesting cases. Now let's move on and look at trigeminal neuralgia, which is another type of pain, but with a different mechanism to the one we've looked at involving the spinal nucleus. Trigeminal neuralgia is defined as a chronic pain condition characterized by recurrent brief episodes of electric shock type pains affecting the trigeminal nerve, which supplies the forehead, cheek, and lower jaw. This is according to the International Classification of Headache Disorders. It is normally unilateral and has characteristic paroxysmal facial pain. What that means is the pain can be intermittent, but when a flare-up starts, it comes in rhythmic bursts for a short time before disappearing again. The pain associated with trigeminal neuralgia cannot be understated. In fact, this disease is often, perhaps insensitively, nicknamed as the suicide disease, due to the high rates of suicides associated with this illness. The pathophysiology of the disease is thought to be demyelination of the trigeminal root, shortly after it exits the pons. Demyelination can arise from demyelination diseases such as MS, or it can arise from vascular decompression by nearby vessels such as the superior cerebellar artery, the anterior inferior cerebellar artery, the great petrosal vein, or the vertebral arteries. It is mostly found in biological females above the age of 50. Current proposed theories of trigeminal neuralgia are the vascular compression of the trigeminal nerve, which damages the nerve and allows for ephaptic transmission. What this means is that the nerve can misfire on its own, or fibres that neighbour the demyelinated nerves can pass on a transmission through the demyelinated fibres too. So a gentle stimulus can be exaggerated and multiple transmissions are passed onto the second-order neurons, making it seem as though a gentle stimulus was much greater than it was. And this is why the pain is perceived as pulsatile and sudden. Because it is mostly found in older patients, it suggests that there is likely an atherosclerotic change within the vasculature of the brain that increases the risk of vascular compression of the trigeminal nerve. On this image, we will be able to see some of the anatomy we think contributes to trigeminal neuralgia. Here we can see the trigeminal nerve and ganglion, and the three branches arising from the ganglion. If we look at the root of the trigeminal nerve, we can see there are several nearby vessels, some of which we have already mentioned. First, we can see the superior cerebellar artery and the superior petrosal vein. In the case of trigeminal neuralgia, there are multiple surgical techniques to help relieve the paroxysmal pain. One of these options is to move the vessel associated with compression of the trigeminal nerve and place a spongy implant between the vessel and the nerve to prevent recompression. It is thought that over time, the trigeminal nerve can remyelinate and the pain will ease. This won't work for other reasons of demyelination, but there have been improvements in pharmaceutical medications to help relieve some of the symptoms. And that brings us to the end of this video. You should now be able to outline the pathways in which pain affects the sleep-wake cycle and hyperarousal that manifest in patient symptoms. Describe the mechanism by which the CNS tries to mitigate pain. Outline the pathways of referred pain within the head and neck. Explain how sinus infections, ear infections, and cardiac disorders can present as craniofacial pain. And explain how the symptoms of trigeminal neuralgia arise in line with current research.